Hey everyone, and welcome back. I'm your host, Harshal, and today we're jumping right into Part 9 of our curriculum. For this explainer, we are putting on our Senior Revenue Cycle Management Educator hats. So whether you're a certified professional coder, a billing compliance specialist, a claim scrubber, or a denial management analyst, listen, this one is built specifically for you. Today we're taking a really deep analytical dive into the hidden traps of automated edits. We're talking demographic, specialty, and procedure-level denials. We're going to break down these complex barriers, walk through some real-world scenarios, and most importantly, build ironclad prevention workflows so you can stop these in their tracks. Let's get into it.
All right, before we start throwing around specific alphanumeric codes, let's just make sure we're totally aligned on our baseline, the critical difference between a rejection and a denial. Think of a claim rejection like getting stopped at the front door. It happens on the front end, usually at the clearinghouse, before the payer even looks at it. It's just a data or format error, like missing info. You fix it, you resubmit it, easy. But a denial? That's a whole different beast. That happens after adjudication. The payer system fully processed the claim and officially said no based on policy, coverage, or medical necessity. Fixing a denial means you're doing the heavy lifting: appeals, pulling clinical documentation, or making hard coding corrections.
Here is our roadmap for today's explainer. First, decoding CARCs and RARCs. Second, demographic diagnosis denial traps. Third, procedure and history conflicts. And finally, number 4, root cause prevention workflows. Section 1. Decoding CARCs and RARCs. To read a denied claim like a master coder, you first have to fluently speak the language the payers are using. Every single electronic remittance advice uses CARGs, which stands for Claim Adjustment Reason Codes. These are the standardized codes explaining exactly why a claim was adjusted or outright denied. You've got your main buckets: PR for patient responsibility, OA for other adjustments, and PI for payer-initiated reductions. But let's be real, the one we battle in the trenches every single day is CO, contractual obligation. When you get hit with a CO code, the provider is contractually bound to write off that balance, unless, of course, you can successfully correct and appeal the claim. Now, if CARCs give you the broad strokes, RARCs, Remittance Advice Remark codes, give you the fine details. They perfectly complement each other. The CARC tells you the general category of the denial, but the RARC is the magnifying glass. It gives you the highly specific clinical or administrative context. For example, you might get a general bundling CARC, but the RARC M144 specifically whispers to you, hey, this service bundles with a pre- or post-operative service. It's the exact clue you need to fix the overarching error. Okay, Section 2, Demographic Diagnosis Denial Traps. Let's move into our first major set of clinical pitfalls, which are the ICD-10 edits that catch claims completely off guard. The golden rule here is that your diagnosis codes absolutely must mathematically and logically align with the patient's demographics and the provider's specialty. Look at these common CO codes. CO9 fires when a diagnosis is inconsistent with age. Think about billing a newborn infant exam, like Z00.110, alongside an adult preventive physical code, like 99396, instead of the correct adult diagnosis, Z001. It just doesn't compute. CO10 triggers on gender mismatches, like assigning fibrocystic breast disease, N60.31, to a male patient record. Then you have CO11, which is a primary ICD linkage error. Imagine linking a routine checkup diagnosis, Z00.01, to a sick E&M visit code like 99214. You'd have to resolve that by making the symptomatic disease, like coronary disease, I25.10, the primary. And finally, CO12. This flags provider specialty mismatches. Unless your nephrologist is out there performing root canals, billing dental pathology K04.7 under them will trigger a hard automated stop. Beyond basic demographics, we run into rigid coverage and validity edits. Take CO49, for example. This is a classic unbundling trap. Say a urinalysis, CPT 81003, is denied because it was billed with a routine preventative exam diagnosis, Z00.01. To resolve this PR49 denial, assuming the clinical documentation supports it, you'd have to link that lab test to a specific diagnostic symptom code like N39.41 for urinary incontinence. We also see CO146 and CO167. These strike when you use deleted ICD-10 codes like the retired C86.1 or vague non-specific diagnoses that just don't warrant medical coverage. You literally cannot use a vague code for generalized joint pain like M25.50 to justify a highly expensive knee MRI. Also, watch your ARCs here. Codes like M64 for a missing diagnosis, M76 for an invalid condition, M63 for a missing principal diagnosis, M65 for an invalid admitting diagnosis, or N56.9 stating the reported diagnosis just isn't covered. These validity ads will absolutely destroy your days in AR if you aren't careful.
Let's touch on one more frequent administrative trap, CO5 and CO58. This happens when the clinical setting legally conflicts with the billed procedure. If you try to bill an inpatient-only procedure code but list an outpatient clinic as the place of service, the payer's system is going to instantly kick it back. It's like trying to fit a square peg in a round hole. It's a purely structural mismatch that your team needs to catch during pre-bill scrubbing.
Moving right along to Section 3, Procedure and History Conflicts, we are now shifting our focus from basic demographics to the really intricate, strict logic between CPT codes, patient history, and timing.
Just like diagnosis edits, CPT codes have their own strict logic gates. You've got CO6 and 7 for age and gender mismatches on procedures. You've got CO8 for scope of practice violations, like a podiatrist trying to bill critical care services 99291. And of course, CO181 and 189 for billing deleted codes or unlisted codes without mandatory operative notes. But one of the most fascinating and challenging denials in this whole category is CO261. This denial outright asserts that the procedure or service is physically inconsistent with the patient's history. The payer is basically saying that the ordered tests lack the clinical history support required to establish any kind of medical necessity.
Let's look at a real-world scenario for CO261 to make this concrete. Here's the trap. A facility bills CPT 81002, a standard urinalysis, but they link it solely to the diagnosis L70.0, which is acne. The reality? The payer's system flags this instantly. Why? Because there are absolutely no documented urinary symptoms or relevant medical history to support the necessity for a urinalysis when treating standard acne. The clinical story on the claim form is basically speaking two different languages, and that results in a swift denial.
Next up, we encounter COB15. This is what we call a dependent code failure. It enforces super strict sequencing rules. It tells you that the billed service requires a qualifying service or procedure to be received and covered first. Another really similar timing trap is COB16. This one hits when the strict 3-year rule for new patient qualifications is violated. So if an established patient visit was improperly upcoded and billed as a new patient, like billing a 99205 instead of a 99215, boom, B16 denial.
So, what does a B15 look like in the wild? Well, the trap is billing CPT 99495, Transitional Care Management. The reality is that if this gets billed before the corresponding inpatient hospital discharge claim has actually reached and been processed by the payer, their system sees a missing prerequisite. The qualifying hospital stay hasn't even been established in their system yet. It triggers a cascading sequence denial. Timing is literally everything with these codes.
And now, we face the infamous CO97 bundling. If you work in RCM, you know this one well. This denial happens when the payer determines that the benefit for the service you're billing is already included in the payment or allowance for another service or procedure that was already adjudicated on that exact same date.
To really put CO97 into perspective, check out this scenario. The trap is billing an abdominal ultrasound directly alongside a Z0000 routine exam diagnosis without any qualifying symptom codes. The reality? An instant medical necessity and bundling denial. The payer views that ultrasound as either an unproven necessity for a simple routine checkup, or they just bundle it into a larger global service. To fix this, you have to apply appropriate modifiers and distinct diagnostic symptom codes to tell a separate clinical story. This is exactly where your clinical documentation improvement teams earn their keep, because without a separate clinical story, that revenue is just gone.
Section 4, Root Cause Prevention Workflows. Look, understanding these edits is really only half the battle. Now let's transition to the final and honestly, most crucial phase of this explainer, implementing systemic defenses. We have to stop these edits before they ever leave your facility.
When you do face a complex denial like CO97, your management analysts need a rock-solid step-by-step workflow. Step 1, meticulously review the denial reason and the explanation of benefits to capture those specific RARCs we talked about. Step 2, cross-reference the codes against the National Correct Coding Initiative, the NCCI edits, and verify the clinical documentation. Step 3. Investigate if a modifier is justified. Maybe a 25 for a significant separately identifiable EM service, or a 59 for a distinct procedural service, or even 51. Step 4. Either correct the claim by appending that missing modifier or submit a robust, well-documented appeal citing specific CPT and NCCI policies.
But let's be proactive, right? Prevention is the gold standard. You absolutely must configure automated front-end demographic scrub rules for strict age and gender parity. That catches those infant-to-adult code traps instantly. You also need to proactively cross-reference your systems with the annual October 1st ICD-10 updates and the January 1st CPT updates so you're weeding out retired codes automatically. Enforce strict review queues for unlisted codes prior to any batch submission. Train your staff relentlessly on proper modifier usage and mandate that your coders are reviewing global surgical periods before they hit submit. By enforcing rigorous pre-bill reviews and internal audits, you transform your entire revenue cycle from reactive to proactive.
And that brings us to the end of Part 9. Your challenge right now is to take these specific CPT and ICD-10 crosswalks and build them directly into your scrubbers and staff training programs. Seriously, ask yourself, how many thousands of dollars in AR is your facility losing this very month to automated logic gates that you could have easily closed yesterday? Don't just work denials, prevent them. Decode Healthcare with Harshal.